That's all right. I'll re-hand you the baton, right? So I'll just talking about how we work together as a team. It's kind of always fun to have, even though we're in different states at this point. When I met Dr. Jane, he was living here close to me and was a student, and now he's a dad and with a wonderful dented wife and their first child. So the way we kind of start through our cases is kind of a typical process. So I'll let you kind of dive in and talk about all the things that we go through.
Sounds good. It's coming up on our 10-year anniversary too, Peter, by the way, that I met you. So pretty.
Or like a present release there.
So anyway, when Peter and I kind of talk about a case, I have to do some things behind the scenes first with the patient. So always a medical and a dental history. This typically will take place during a consultation that I'll have with the patient. And during this consultation, I'll have already taken all of my diagnostic photos. I'll take x-rays, and I'll take all of this information, gather it with the patient's chief complaint, and kind of have a conversation with them, figure out if they're right for me, if I'm right for them, if I can help them with what they're looking to do. And what we really want to do is figure out what the risks are with whatever treatment we're going to do, and whether it's going to be comprehensive or conformative. So conformative meaning we're going to maybe have to compromise on something in order to get that end result that we really need.
Sure, my slides aren't changing yet. So my slides aren't changing well, but okay, let's start with this grief then.
Okay, so this is Michael, and Michael came to my office from a periodontist, and he wanted to do something about his smile because he couldn't chew, couldn't function, and he quoted and said, "My teeth are disappearing." He's young, upper 30s, and the first thing I look at when I take all my photos is, how did we get to where we are right now? And if we scroll through one more time to the occlusals, we can see he's lost a ton of enamel. And we know this can't be a strictly grinding problem because he's got cupping of all of his tooth surfaces. So in order for it to be just attrition, it would have to be everything flow. But we know that there's a chemical component. So during my conversation with him, we discussed what might this come from. And we kind of decided that it was due to GERD, undiagnosed gastroesophageal reflux disease. So I talked to Peter.
Interesting on this case is, during our conversation, we both kind of saw that, which was nice. And you went back to the patient. I think also we did some digital casts here. So Dr. Dane sent me a digital impression of this, and we got that mounted. We can look at the space we had to work with, something partial dimension, restorative options, are kind of working through our conversation to really have an understanding of it. And now that we have the medical history, it almost starts to become, I don't want to say simple, but a little more simple to start working through the process. We're going to do all the things that we normally do, deciding where we want the sides of leg position in space, and then the vertical dimension. We have to, how much he's already prepped the teeth for us, in essence, right?
Okay.
Where we want to place our margins and where we want the occlusal scheme to be once we decide where the incisal edge position is going to be in the face.
So as Peter said, Michael pretty much prepped the teeth for us. I try to get an additive wax up as much as I can because I don't like cutting down teeth. So really, in this case, the only thing I had to do was essentially break interproximal contact everywhere and make a nice little chamfer for him so he could build the upper restorations. So we provisionalized them first, and then we seated all of the uppers up top because I was not super comfortable doing all 28 at the same time.
So this was kind of
Look ahead.
And I would love if you just touch on this second, because this is such an important process, especially when we're doing these larger full mouth cases. Did I lose you again?
So here we are. Uppers are all in, and Now I need to do the lowers next. And what I realized is we need to do a little building up on the lowers. So I made a little Lucia jig at the desired location of where my lower anteriors were going to be. I made some bites. So when I did build these up, I had the bite to reference back. And you can see I prepped the lower posteriors first. And we put those in and then finished up with the lower six.
But the key here is that you left these anterior 3 to your Lucia jig, right? That was really the key to manage vertical dimension. And I hope you'll tell me that when you put the lowers in, you had very little adjustments to make because of the bite risk.
Pretty much none.
Yeah, and that's what we want, right? We should say it's that way. I'm like, maybe not, but that's really the goal. And if it did work, it worked because of one little step. Upper plane was established. A bite with registration was taken with the Lucia jig in the CR or the MIP position. And then the preps were taken to the opposing dentition, which really made it easier for me just to follow the occlusal scheme that I had already established on the upper arch. So it kind of made it a little bit easier. And then the goal is to keep it simple for the insert. I would say that a case like that seems pretty complicated. And obviously, sometimes those are really complicated. Sometimes working in less areas isn't easier. I think, doing a single tooth like this, I could tell you that, Dr. Dana and I probably struggled to get this as perfect as we wanted it when we did an additive veneer on a non-prep lateral that we had a big blend in. I think you use this for an AACD case. So, to go through all these details and try to make something harmonize as much as we possibly can. And I've showed this before, probably over the years. And I even pointed out some of the flaws in it for me that I wish I would have done things slightly better. But in general, it worked and the case is fine. And sometimes these are more challenging. And just because 1 unit or 2 unit that we do doesn't mean it's easier. There's probably more, and I don't know, you'd probably agree with me, there might be more communication on these smaller cases than there are sometimes on these larger cases because we have more control of the larger case. Whereas in these smaller cases, so much more color information, material selection, and blending it in or harmonizing into the patient we're working on becomes so much more challenging. So this is Carlin. Carlin, we're doing, and I'm going to say kind of a transformative dentistry. She really just wants to fix those 2 central teeth. And we felt comfortable that we could do that. So Dr. Dana did his normal, beautiful preparations, again, trying to stay minimally invasive on those preps. And you can see, I think part of our teamwork with any of the doctors that I work with is a checking. We're always checking on our teammates, right? So he's checking on me to see that my margins are sealed, that my information right, and my restorative aspect I've done well. And I'm checking on him that my registration is correct and the marginal placement is good and the prep facial position is where I need it to be. And you can see we're really minimally invasively restored here. So we don't have a ton of space to work in. We don't really want to keep prepping if we don't have to. Built this up as a max veneer case. And I finalized the case just as 2 feldstatic veneers. All I'm really thinking about at this point is what my enamel finishing is going to be. I want more of a milky or a translucent or a transparent type enamel. And I'll send those back to Dr. Dane and he'll go through his procedure to place them in. That's actually your finger there, Dr. Dane.
Yes, yeah. So Peter nailed on it. A 1 unit or 2 unit case is so much more challenging because we have to match it to the natural teeth. So a lot more is at play rather than just telling him, 1M1, 10 units across the top. So this is how I put in all of my restorations that get bonded if I'm not luting them. So I use rubber dam isolation, and there's a case coming up that I'll show with some close-up photos, but you can really see the margin perfectly. You can see if the veneer is seated on the margin. And I always do my try and prior putting this in and get the patient's consent. But it just makes it much more simple for me to put them in this way. And I have complete control over everything.
And I would argue from my point of view, this is a fabulous technique. It's a lot more work, but it's got so many wonderful aspects to it. The key words that the Dane said was he's trying everything in first for the aesthetic look of it to make sure the incisal edge positions and angulations are all good, because once he's into this, he's kind of blind, and he's blind in the aesthetic parameter, but he's almost like he has x-ray vision in the parameter, right? Because now every little margin is detailed, which means on my end, I can't miss anything either, right?
Sure.
Yeah. And he's seeing every little aspect of it. My margin is a micron shy somewhere. He's going to see that better than he ever would have seen without having it dammed off.
So this is what it will look like after I bond them in, and then I just pull off the dam, and this is immediate after. You can see that the centrals look a little darker because of the dehydration of the other teeth, but this is her after 1 week, and I expect even better papilla ingrowth there between the two centrals. And if we do one more zoom in, I probably could have maybe shortened number 8 a hair.
I agree. Yeah. So never too late. So beauty of a rubber wheel. So this gets a little more complicated. So this is Mary. Now we're going to go to 4 units, and Mary is doing a licking of the silicate cakes. Again, I wouldn't call this a conformative dentistry, right? Because there's only 4 teeth that we're doing. And when we're doing 4 teeth or 2 teeth, we don't really have control. But this case got a little more complicated.
So I called Peter about this case and said, hey, we're going to do 4 units here. She's planning on doing grafting. So I'm going to make my margin, not all the way to the gum. But I want to be minimally invasive, but at the same time, she's got mobility on all of these anterior teeth, uppers and lowers. And she said for the last 50 years, her bite has just not been right, and she has a lot of trauma from occlusion. And her daughter and her husband are both dentists, and they referred her to me. So I have a little bit of a challenge. So it wasn't until my conversation with Peter that he really told me, why don't you just put in a leaf gauge, open her up a little bit, and spot bond composite on her upper teeth. That way you can get some of the load off of the front teeth. So that's what I did. Leaf gauge on the left. I knew where the bite was.
Concern was obvious when I see this. This is a red flag for all of us, and I know Dr. Dane are too, right? We see the chipping on the upper teeth. You see the chipping in the wear on the lower teeth. Obviously, ortho is an option to move teeth, but because she already had some mobility and some other issues, I guess that really didn't work. So our only goal at this point was, normally the protocol is what? When you have an envelope or a functional constriction, our normal goal will be orthodontically to move the teeth out of the position, or to vertically change the tooth position by opening the arc. Either one of those is fine. The third option that we don't always talk about as much is tipping the upper anterior teeth out a little bit more. You see that her teeth did appear a little legally fine, so we did have a plan to tip them out, but we still didn't feel comfortable enough with the tipping that would fix all our problems. So yeah, Dr. Dane did a great job. He just put a little leaf gauge in there. He opened her up, and he went back and did some spot composite bonding, and gave us a little bit more freedom in that envelope to protect our final restoration. And we did our normal stage protocol with the 3D guide, trying to narrow down all our information. And Dr. Dane used a T technique where he picked my wax up, placing it right over her teeth, and using that to prep through.
So I did 0.5 millimeter on the front because she had pretty good prep shade color, and 1 millimeter, 1.5 millimeters incisally. So I took the wax up, I put it on the teeth, and then I prepped through, marked the pencils, and prepped until I erased the pencils. And then you can see some of the teeth didn't really get touched at all. If you go to the next slide, Peter.
Here's the beauty of that, right? It's because if you look at these teeth, you can see they're a little legally fine. So even though you did a little incisal reduction, as you get to that prepping away of that incisal edge, you're not really prepping as much. So that's not going to really be the area. The area of concern is going to be more in these areas where the tooth is a little bulky. And you can see some of the coloration is coming through there, but we're tipping those teeth out.
So from the left photo to the right photo, I'm just taking a scaler and popping off the rest of the bisacryl material. So very, very minimally invasive, the prep. I think the one that needed it the most was the upper right lateral. And then I'm just putting a chamfer margin on all of them, taking my prep shade photo. And this is an important step here because when she's been open now for probably a good hour doing numbing and shade communication, and me taking all these extra photos that I typically wouldn't take. So what happens is the teeth dehydrate. So in order for me to transfer accurate prep shade to Peter, I have to get the teeth kind of back to how they were. So I'm going to use a glycerin gel, which is almost like what you would use for your polishers. Is that right, Peter?
It's actually
your polishing paste.
It's
glazing.
1% or 2% glycerin in it. But the gel form is a different viscosity, right? So you can actually paint that on.
So that's what I'll do. I'll kind of paint that on, and it almost gives the tooth like a new light, because it's almost impossible to get the exact color to him unless I brought her back and then really quickly took off the provisionals after she's been rehydrated. So using that gel is a pretty good way of accurately transferring that to him. And then I make my provisionals, again, from the same wax up that we had. And you can see here that the color is much more uniform because some of the teeth I had to prep away that yellow that showed through from the previous slide a couple photos back. And here is me trying them in first. And I put my rubber dam in place, and you can just see how the centrals now are bonded, but now I'm doing the laterals next, but how well the chamfer is defined. And then the dry try-in will be next in the middle slide. And you can see how nicely that elbow is. And then the photo on the right was after it's bonded. And here she is 1 week only after we put them in. She, again, still has papillas to kind of come down, but we know that they're going to come down because of where the prep margin is in relation to the interproximal bone. So it's where she was very happy.
Yeah, real simple one. I don't want to say simple. I mean, look, anytime we're trying to match to something else and bring the feedback, it's great. But each of our cases in this section that we're doing is kind of, you'll notice each one's getting a little bit more complicated. So this is Maria, lovely woman. And you can see there's a lot of, let's say, disharmony happening between her pretty face and where the teeth are. So I call that a visual tension, where you start to look at the teeth and your eye starts focusing on areas that you don't want. Like these areas seem to pop out, then the discoloration and the angulation is more just, you have all these little disharmonies here that create a little bit of a visual tension. And this is going to get a little bit more complicated because as Dave and I work with the case, we realize that the right thing for her to do is going to be really some orthodontics.
Yeah, so in order to be pretty minimally invasive, I don't have an occlusal shot, but you can see how that upper right central, if I started prepping these teeth, we'd have to do a ton of endos. So I chose to do some orthodontics just to move the teeth in a better arch form, as well as to get the gingival harmony a little better. And after we did that, we got her to this position here. Still a cant, but at least now we're pretty level across the board when you look at the gingival heights and where the zeniths are on all the teeth. So we did some extruding
to cut in a little bit, but this is such an important point too, right? If you don't mind me saying, because I think over the years and all the clinicians that I work with, we've been really adamant about the importance of orthodontics and when to move teeth, and also when not to move teeth, right? Because there are some cases where we look at the age of the patient, the density of the bone, the type of movement that needs to be done, that we're starting to get to the point where we realize maybe ortho isn't the best scenario. Maybe we're better off prepping the teeth orthodontically and restarting them where we. But whenever we can move the teeth and we can put them in a position that's fair for the patient, being that we want 5 years to get the teeth where we want them to be, then I think it's better off that we do some orthodontic like we did in this case, and we wound up not only leveling out the teeth, saving a lot of suture on her. Here's your head. So then you provisionalize the entire upper arch. And again, some beautiful preparations that came back from vein. At this point, when you're taking this photograph, is this one or do you have it, right?
I think that is just one cord, yeah.
So, and you're doing the same thing. You're trying to put some of the glycerin gel on there to get some color to come through. And you're just sending me that one more photo before you put your final matrix back into the wax.
Correct. Mm-hmm.
So I get the case. This is what I'm seeing, right, in my office, the final preparation, then the prep. I'm not sure if you guys catch it, but, my first thought was, as great as the prep looked, and obviously the reductive area and the incisal is probably going to be fine. Look what happens when I'm looking at the preparation. You start to see right away that I'm seeing some of that preparation come through there. So that either means that I didn't bring my wax up out far enough, or that the vein didn't reduce enough. We're going to have to make a decision at this point. Which direction do we want to go? I'll kind of analyze that and say, yeah, if those preps are right there, we are trying to stay minimally invasive. That's why we did all the orthodontics, all the things that we would normally do. So if that's the case, then we're going to have to maybe sacrifice maybe a hair more forward, bringing the teeth out 0.3, 0.4, 0.5. Or I could suggest a trimmer coping. We could remove some more of the tooth structure. But we didn't really want to do that. So this is going to be a real minimally invasive restorative case for me. I wound up treating that with lithium disilicate with micro layering, right? So very, more monolithic, but I do want some layering on there for many reasons. And part of the reasons why I want the monolithic, I don't want the monolithic, is because, as many of you know, I think lithium disilicate is such a challenging material these days with the lower value and kind of getting the gingival harmony that we want. And I was actually proud of this case because I made the embryos so thin that I was able to actually layer a little bit more around and also do some micro layering up towards the incisal. So if you kind of look here, this is kind of the important part of this case, is how nice the gingival tissue look against the micro-layered lithium disilicate. I think is really important. And I've showed a billion times in lecture how, whether it's lithium disilicate or even a metal ceramic coping or a zirconia coping, that all of those kind of shadow the gingival tissue. So that's one of the reasons we get that grayish hue. Anytime we can get light into there, I know I've showed a billion lectures with fluorescence and so forth, but anytime we can get light into that tissue, the tissue is going to look a million times better. It's going to really help us through our cases. So choosing the right material and being able to do some micro layers on it is really going to add to that result. And we'll finish up with this case then, if you want to walk us through this.
Okay, this is Debbie. And Debbie has pretty bad periodontal disease, a lot of mobility in her teeth, and a lot of failing restorations. And after kind of discussing with her that we need a long-term solution to her mouth, we realized that we're going to have to take out all of her, at least on the top. So part of her problems or her diagnoses, she's got a mess with the gingival architecture. She's got tons of bone loss, as you can see, furcation issues, caries, mobility. She has a high smile line, which is big red flag. And when we did talk about options for hybrid, for instance, she said, I don't want you to take away any of my gum or my bone. So where does that leave us? We have to do some sort of an FP1 prosthesis. So that's kind of what we chose to do. Implant supported bridges to make things worse. She wanted to be able to flop between her teeth. So I said, well, we can compromise with some bridges. Would that be okay? She said, yeah. She did not want one piece. She thought that would be too much like a denture. So this required a lot of thought on Peter's and my part of where we're going to put the implants, as well as the periodontist, and how we're going to transition her from where she is to where she's going to have no teeth with implants already in place, so we could pick these implants up without compromising the implants, loading them immediately. So,
yeah, if you don't mind me jumping in here, I think this is such an important point. Look, today, everything is about all on, right? Everywhere I go, I think I'm speaking in Spain next week after, and I promise you people will be showing all on cases, and I'll probably show one too. But I was in London last week, and every lecture I saw before and after me was, all on cases, all on. And this seems to be where our industry pushing harder than ever. There's some good things to it, and there's bad. Everything we do, or it's the issue, the theme, critical. We knew how we should do it, and what the patient's comfort level is of us removing not only their bones, started, and how many dramatic it did that. I get it. The ease of what our profession is pushing these days with Paul, the teeth, forcing the pipes, and diving in with a monolithic glazed restoration. I would make the argument that if you're putting those teeth without any support. So we did spend a lot of time anecdoting what we thought was best for our patient. And in the end, this is what we came up with.
So we have a failing bridge upper right, but we had good bone pretty much everywhere. That was the saving grace of this case. So my periodontist put a couple implants underneath those pontic sites, which meant I had to take off this bridge and provisionalize it for him to do so, and then re-cement it after his surgery. And then he put a few implants on the left side, and she was okay without a flipper on that upper left, kind of going a dentureless for 3 months. And she was aware that it could have been a little long. So at this point, we've got 5 implants in place. And this is where I said to Peter, hey, I want to wax up so I can pick these up at the time that he picks out the rest of the teeth and puts the implants in. And this is communication is so, so important. Peter said, why would you do that? That's going to be a lot of extra work for you. You're going to have to use the temporary cylinders and pick up all those new implants. Why don't you just take a fixture level impression and let me do all behind the scenes? So that's what I did. I took out the bridge again, and we took a fixture level impression, and that's where the wax up was made from. So I took photos at this point in Jaw Record, and Peter did a wax up.
Yeah.
Go ahead, next slide, Peter.
With that photo in, I'm sorry that I did, but I guess I did.
And then, so now we're ready for the surgery for her to get the remaining teeth out. So the bridge that's provisionalized in that upper right, we're going to take out those prep teeth, and we're going to take out those front 4 teeth and put 3 more implants in the front. So we're going to have bridges from canine to central to canine, and then from premolar back to the first molar. And you can see that the tissue architecture is preserved for some customized healing abutments on that canine and premolar. And the surgeon took out all the teeth. Go ahead, next slide.
Yep.
And he put the 3 more implants into the 2 central spot, as well as that other canine. And next slide. Oh, okay. So go back a slide. So at this point, I had the provisional that Peter made for me, and I had 5 good implants that were already integrated because we waited 4 months. So we're not going to touch the 3 new implants that we just put in. So we're going to load the 5 implants, and we're going to make pontics on all of the sites that are going to go in the pontic areas, as well as the new implant areas. So my part took 5 minutes. The whole entire appointment up to this was a couple hours. So I dropped the entire screw retain bridge in one shot, tightened them up, closed the access with composite and Teflon tape, and Debbie walked out like this. So after she woke up, because she was sedated, go ahead, Peter.
He hasn't seen them yet either?
No. Oh, wow. Oh, wow. And these are provisional.
Yeah, they're not the real thing.
No. It's amazing that I could be seen in public.
Well, the real things look better.
Oh, yeah.
Oh, yes. Listen to that back there. Oh, yes.
We do have sutures in between them right now too. So you're
So interesting, right? Because I think that's so important that, it's funny. I was in Indiana a few weeks ago and we were watching a bunch of surgeries and all the placements. And it's such a challenge. Again, when you're going in that all-on world, not to beat up the all-on world, but it's such a challenge to bring the patient from zero to something and get that accurate. I think the saving grace in this case was the fact that he had those front teeth and and spacing it out to be able to place those implants over a period of time of 2 months healing and then come back and do the rest. I get it in the all-on world. Everybody's taking everything out and putting them in one day. I honestly think that's crazy. I really think if you can stay, it takes longer, but it's much more controlled and it's much better environment for the patient. And it just seems like it's the better place to go. I will also throw in that a lot of these in-a-day kind of cases that I see, we wind up going backwards a lot of times where the patient leaves with teeth in a day, and then we look at the aesthetic parameters of the teeth in a day, and when we're going to go to a real final restoration, it's almost like we're starting over again. Me and my restorative being the dentist that I'm working with to get the incisal edge position, the midline, the buccal power door all right again. And it's kind of frustrating because the all in the day both are kind of getting paid and dropping out after that. And then we're left with the final. So I feel like we managed this case. Dr. Dang was really smart and great for her in the sense that it took a little longer, but it gave us a better result as you described it.
Yeah.
Peter, not to mention that we're sparing all of her soft tissue and bone. So if we do, God forbid, have an implant that fails in the future, we can retreat it very easily. Whereas if you have something that fails, you already whacked away 4 or 5 millimeters of bone. Now you're talking about pterygoid implants and zygomatic implants. So we want the fact that we're doing some of these all-on procedures and young people, 30, 40 years old, like what's going to happen to them when they're 9, when they're 80? I doubt their same procedure or the same prosthesis will still be in place.
I actually said, it's a little controversial to say this, but I'm going to say it. And there was a period of time between, I think it was 2012 and 2018, where I gave 4 zygomatic arch cases. So that's where the patient has no bone left and the implants are all the way up into the zygomatic bone. Between 2018 and now 2025, I think I've done like 9 or almost 12 of them. So the zygomatic implant world is growing, and I really believe is exactly what you just said. It's because we're breaking out teeth, we're taking away bone, we're putting implants, and we're putting very rigid material on top of those implants, and we're seeing more implant failure down the road. In her case, we're kind of in a great spot with her, and I don't want to jinx us, so I'm not absolutely, but just more implants, but she spent more on the implant placement, but she still has flossing ability, and we have retrievability, right? So everything can be unscrewed and fixed and cleaned if we needed to, if something breaks the chips. By the way, we did this old school metal ceramics, which you'll see in a minute. And the beauty of it is if there is a failed implant down the road, we have the ability to either re-implant or basically attach to probably the other police part. So we still have options that get there be through a long period of life, kind of our goal. So you see here all the final fixture level impressions. At this point, we would normally do what we call an implant verification, Jake. We didn't need to do that for this case because we're not doing it online. And actually, we just took a normal fixture level impression. And because we're treating it as a crown and bridge metal ceramic case, we kind of have the ability of not worrying about the passivity of fix. Obviously, we're worried about it. Let me say that differently. It just means that if there is an issue, if we feel like one of the transfers is off, we could do a cut and connect where we don't have that luxury with zirconium material. So we're going to follow the provisional matrix that is in the patient's mouth. We're going to design 4 3-unit metal frameworks. And I'm going to send that back to Dr. Dane to try everything and verify. How were the fits on those? Remember, Dr. Dane?
Perfect. And going back to what you said about zirconia, I've had a case where I have had a bridge zirconia and I go to try it in and I didn't realize it was passive until I started screwing it down, and that you could hear it from the guy next door. It just cracked. So there's no give whatsoever to zirconia. So I do actually think you get a nicer fit with the metal a lot of times. So I just kind of gave it to Peter and said, whatever you want to do with it, I'm fine.
Yeah, and I think, listen, I think both of us and your wife, for that matter, do Dr. Renata does so many of these all-on kind of cases. Since we're not saying we don't do them, we do. I think what we really try to do is be very cautious in who we're doing them for, where the implants are placed, and the amount of space that we have to work. And I think that's where the misnomer is, or the misview in the profession today, is it seems like we're turning everything into an all-on for, instead of stepping back and thinking through the process of realizing what's best for the longevity of the case as we go through. So in this particular case, I chose old school metal ceramic. So just a simple VM13 case. We pressed out the metal, we opaque it. You could see here, by the way, and this is a testament to your direction to the surgeon, because you didn't place these implants yourself. Look at the placements here. I mean, look at these screw access holes on everything. It's almost perfected, right? So that makes it so much easier to manage this process with the ceramic materials.
And not too that a lot of these implants were placed immediate after taking the tooth out. So he didn't even stage it by grafting. He put them in the same day. He's an excellent periodontist. So it definitely whacked a lot of time off of the total treatment time.
Yeah, but I mean, always really challenging, even no matter how good the surgeon is, how many surgical guides you use. Boy, there is such a challenge, especially if we get more towards that anterior section, to kind of make everything work well. So this to me is really impressive. I get it on the posterior. That's a little easier, a little simpler. But once you get here, I can't tell you, a lot of times we start thinking right away that we'll be making a soft abutment, maybe set screwing one of them the correct angle, or use an angle screw channel. But no, this place was really perfect and really made it great. So I started my normal build up here with some opaque dentins, some dentin materials. And then I started bringing that into everything I would normally do in my build-ups, right? Some translucency towards the insides or lenses, some nanolines, some structures, and some changing of enamel. And I actually fired this to look at, what am I trying to get to? You'll notice that I didn't build in a ton of translucency. I wanted to kind of keep it a little bit more of a simple piece of attention. So there's my first fire off the cake. You can see that I have some trinity, not still with color. And going more is the pattern at through the meta one and offer iteration. I use wider or more of a transparent. Yeah. Usually a lot of times if I'm using 9 systems with a 13 to a whole. I very rarely use the EN out straight. A lot of times I'm mixing in a little bit of a window to it. And if I use it straight, then I'm using it more as an effect powder, almost like a whiter powder rather than the EE1. So that's how I'll control that. Teeth are a little wider than I probably would like them to be. Maybe I think we're at the fine angles in a little bit more. In the end, we are trying to close off that papilla state, so we needed that extra little width for them. And it's always good to kind of see where our patient started and where she starts to finish up. And there's Dr. Dane doing his thing at the end with a little bit of, what do you call it? A tap
Flum. Mm-hmm.
And inclusion-wise?
Inclusion was perfect. Yeah, she was great. We also, if you notice on that retracted shot, we did some lower bridges as well. So she got 4 more implants down on the bottom.
Great. And there she is. So there's our final patient. And I think that kind of works well. I think that's really the things we do. I think we did a pretty good job on time there, Dr. Dane. I was worried that we might be running long. So maybe I can add an extra slide. When I'm solo, it's easier to fly through stuff. Sometimes we went back and forth. I was worried. I think we did it. That's how we communicate. Obviously, there's more to this. There's photography, which we didn't touch on really just for times. I think anybody who watches my webinars knows I talk about that all the time. I think the real key, and I'd like your opinion on this, but I think the real key is these, again, state to state and place to place of these phone conversations, these photographs, and those are the two of us kind of diving in and thinking together. And I'll honestly say that I have the luxury of doing that with the 10 clinicians that I work with. Every one of them, if one of them is here in my lab every now and then we're on the phone and we're talking, we're communicating. And by the way, not me. Sometimes, Dr. Dane, I feel like you probably talk to Jen and Keon more than me sometimes, right? In the sense that
Sometimes. Yeah.
So it's that team kind of a concept. So I don't know how you feel, but that's the way I see it. I think that's really the key to success. It is the teamwork.
Yeah, completely. Peter told me everything about photography that I know, so it really helped to be on the same page with him. And the fact that I could be in Cincinnati, Ohio, and he's in New York, and we can get the results that we do just through Dropbox and communication with photography and talking, it's amazing. So I'm very grateful to Peter for kind of blossoming my career in the direction it's gone. So thank you so much.
Well, thank you. But I'm grateful to work with you and to watch, to be part of your life, right? To see that, the effort you made from day one in school to where you are now, and you're not a baby. So yeah, happy. So thank you, Di, for starting and being a part of this. And I think hopefully we'll have some time for some questions. I'm impressed that we actually got through that without running over. So good job there, partner.
Yes, I know it. Excellent job. Great job. And I think you guys demonstrated how well the things work out or can work out, or at least work out solutions when there's good collaboration and teamwork. So thank you very much for showing all those. I'm going to go ahead and take over here, show the end of my information here. So we will. All right. So those of you that are asking about the CE, we are either going to send you a letter or send you the information for CE. We'll go ahead and forward that into the appropriate NBC and so forth. Again, the workshop, this webinar was recorded, so you can go back and visit it as well at the VITA North America YouTube channel. If you need to get a hold of anyone here from the VITA North America, here's some information here on everyone. And then we have some additional webinars planned, courses. We still have some openings for our Germany workshop. Those are denture courses, the end of May and first part of June if you are interested. But we got a ton of webinars coming up. We have a ton of webinars that we've been doing over the years. So please visit us again at the VITA North America YouTube channel. And then Peter's been gracious enough to provide his information. If you do have some follow-up questions that we don't get to today, certainly go ahead and notify Peter. Just remember, Peter is, of course, a commercial lab, does a lot of large case, small case, travels, does lectures all over the world. So if he doesn't get back to you right away, just give him a grace period to get back to you. As far as questions, so let's look at some of the questions that we have. Why do the upper arch first in a full mouth rehab? Why is the upper arch done first in an upper mouth rehab? You go to that one.
I think when you're looking at someone's smile, the first thing you're noticing is where the teeth are in the face. So we're not just looking at the teeth, we're looking at the whole picture. So we're treating the patient first, the person. I think Peter likes to say that, the person, then the white, then the pink, then the macro. but we're looking global first. We want to know where the incisal edge position should fall. When we're making a denture, the first thing we do is we set the front central teeth. So step one would be the front, and then we kind of go back to the posteriors, and then by knowing where the OVD is going to be, that's when the lowers should just drop right into place, depending on our occlusal scheme.
Yeah, I think that's that's the perfect answer. The bottom line is aesthetic starts with the incisal edge position. So step one for us is always. I don't know who asked the question. I'm going to make the assumption that when I first learned, I learned lower incisal edge position too. That was a typical Dawson pancake concept over the years. I never agreed with it back then, even when I wasn't, smart enough to figure out how to suspend it. I didn't think it was correct. And I still, to this day, really transitioned. Everything starts from incisal edge position, occlusal plane, and then the lower teeth for the functional envelope. So it's standard for us never to do the lower first if we don't have to.
Right. And then we have another question as far as in the case with the patient that had chemical attrition on their teeth, what's the best restorative material that can help in the future so that it doesn't eat away? Do you guys have any experience on the materials that work best under those patient conditions?
Well, I'll dive in.
I think the first thing, go ahead, Peter.
Case I forgot to mention before. We just wrote up that case will be appearing in IDT next month. It's actually the short article together that we did. So there'll be a lot more detail on that case that we didn't go into. But as far as so check out IDT next month for that one. As far as the restorative option, I'm going to let you kind of dive in because I think that question could be two part. One, when there's chemical wear, like we saw there, you really need restorative, right? So there's really no option. The question is how much restorative we do and what material we select. I'm not sure if their question was more geared towards managing the GERD in this case or the chemical erosion. Was that really more of the question?
Yeah. Okay. Yeah, no, we're fine. We're good.
Was the question geared towards how do we manage the erosion on the teeth? If that's the case, of like the perspective, or what material works best when the teeth are eroded to cover the teeth? Right? There's two different folds.
So for me, obviously, the first thing we need to do is control the GERD. But Peter and I decided we can't do adhesive dentistry here because we do not have enough enamel. So we decided we had to go 360 with our preps and do fully retention resistance form preparations, which luckily they were pretty much done for us already. So we didn't have to do a whole lot as far as prepping.
Okay. And then another question, when you applied the gel, you're talking about that gel to hydrate the teeth. After you apply it, how long do you wait? Do you wait a few minutes? Is there
No, you just put it on it. It's kind of like a coating. So right away.
Yeah.
You don't want it to be too thick and globby. So just thin enough that it coats the teeth and kind of gives them a little bit more color.
It doesn't really rehydrate the teeth, right? What it really kind of does is give you a shiny surface to see the coloration of the teeth. So but that quick filling gel is nice, actually.
Okay. And then another question was after the Invisalign treatment on that one case, does it generally need an ortho wire to stabilize? And if so, how long?
Good question. I don't do wires, but I do make them Essex retainers as they're in their temporaries. And also in case anything ever were to happen with the temporaries. And then after they finish their restorative, I'll make them their final retainers. So as long as that final retainer is made very quickly after the teeth go in, you should get pretty good retention. And I will wear that at night indefinitely.
And then another question, for the implant case, question was, what was that provisional made out?
That was MMA. Metal reinforced, I believe.
Yeah, we did make metal reinforcement because we knew there were more implants being placed, and that was going to take another 3-6 months-ish time. So we wound up making a metal reinforced provisional, but the final material was just PMMA. And that we have a nice technique on that. And by the way, you can mill some of these sometimes. We did a metal reinforced footprint, obviously, today. But because it was metal reinforced, we old schooled it where we actually did an injectable. We mix up our PMMA, make a mold, and inject right over the front part.
Okay. All right. Well, I think that kind of wraps it up with all the questions. I want to thank both Dr. Dane Avendolio.
Hey, good, Jim.
For taking your time out to work with the people who want to get educated. And I think you guys did a great job to fulfill that request today for team communication and so forth. So great case works. I'm sure you guys are going to do a lot more in the future, and very interesting indeed. So I want to thank you for joining us today. I want to thank everybody from the audience, for joining us today. And thank you very much. Any last minute words from Dr. Dane and Peter?
Just thanks for having us on, Jim. Appreciate it, and hoping to do some more in the future.
Yeah, no, that'd be great. Fantastic.
See you guys soon, and look forward to our event in Spain coming up, the VITA Rocks event. I got to make a video for that today, and that's going to be a great event. So it's going to be a 2-day event in Jerez, Spain, which I'll be at the week after next, and I'm looking forward to that. So
excellent
for attending.
All right. Well, thank you everyone for joining us, and this will end today's VITA Academy webinar. Thank you very much for joining us. Have a good day, wherever you may be.